Hello, everybody. My name is Ioana-Irina Rezuș, and my PhD is about the management of pancreatic cancer from diagnosis to treatment. I'm a first-year radiology resident with a vision to have a better management for patients with pancreatic cancer, and for that my mission is to assess new diagnoses and treatment methods and implement them into healthcare. I have two ongoing projects. The first one started in September last year, and it is about the efficacy and safety of therapeutic procedures for chronic pain in patients with unresectable pancreatic adenocarcinoma. Pancreatic adenocarcinoma is currently the sixth leading cause of cancer-related death, but it is expected to become the second one by 2030. Between 80 to 90% of these patients are diagnosed with unresectable disease, and almost as many have pain at the time of the diagnosis. Unfortunately, the available medical treatment consists mostly of opioids, which is still associated with inadequate pain relief in more than half of the patients. But there have been emerging more interventional ways to address this pain, and we aim to find the most efficient one of them. So we phrased the question, which method is more effective and safer for pain management in patients with unresectable pancreatic cancer, with the population being adult patients, interventions and comparators being any kind of pain management. Our primary outcomes are pain relief and quality of life, while our secondary outcomes are adverse event survival and analgesic drug use, and we decided to include only randomized controlled trials. Our hypothesis is that interventional methods can provide better pain control. We performed our search on 29th of October last year with the search key you can see on the left side of the slide in 5 major databases, and you can see the number of hits in the brackets. We started with almost 5,500 articles and ended up with 21 full-text eligible RCTs. Luckily, we have all our analysis completed, and I'm going to present you some results for pain and adverse events. First, pain was our primary outcome, as pain is the most debilitating symptom in patients with unresectable pancreatic cancer. Usually, pain was assessed on the VAS scale, which ranges from 0, meaning no pain, to 10, meaning the worst pain possible. And here we can see the results for the baseline pain. We have more intervention groups. The 4 groups are one-time interventions, 3 types of different approaches for the celiac plexus neurolysis, and 1 group for the high-intensity focused ultrasound, while the last group consists of opioids, which meant a continuous daily opioid intake. As we can see in the pooled means, in all of the study groups, pain ranged from between 6 to 7, which means a severe pain. Because we wanted to see the dynamic of pain in time, we also measured pain at 4, 8, and 12 weeks. And at 4 weeks after baseline, in all of the study groups, there was a decrease in pain scores. However, at 8 and 12 weeks, in all of the study groups, pain started to slowly increase. We could see that at 12 weeks, the pain is lower in the endoscopic ultrasound celiac plexus neurolysis group. However, the number of studies included in this analysis is too small to draw a definite conclusion. If we look for the adverse events, I decided to present you results for 2 adverse events that are usually associated with celiac plexus neurolysis. And here we can see results for diarrhea, which was defined as a transient adverse event lasting between 3 to 5 days after intervention. And for the endoscopic ultrasound-guided intervention, the risk was 11%, which was smaller than the risk for the percutaneous intervention, 23%. Again, for the cardiovascular events, these were also defined as being transient, lasting almost 5 to 7 days after intervention. And the risk with endoscopic ultrasound neurolysis is half of the risk with percutaneous neurolysis. The adverse events were defined as being hypotension or orthostatic hypotension, with just 1 study mentioning the need for inotropic support. The strengths of our study are that we included a large number of diverse procedures, and we measured the outcomes at multiple time points, and we included only randomized controlled trials. However, the total number of articles was low. We had a high heterogeneity among them, and the lack of gold standards to assess pain and quality of life made our analysis even harder. Our conclusion is that minimal invasive procedures provide pain reduction with fewer associated adverse events, and the endoscopic ultrasound neurolysis seems to perform overall better than the percutaneous one. The implication for practice is that these procedures should be considered more often and earlier in the management of patients with unresectable pancreatic cancer and pain. And for research, there is a high need for further RCTs that compare directly different interventions between them, and also one-time intervention to multiple repetitions. This is the progress of my first project. I have completed the manuscript, which went to internal review, and we aim to submit it first in the Gut journal. The second topic is about the diagnostic performance of different imaging techniques in pancreatic cancer diagnosis. Pancreatic cancer has a very poor prognosis, and resection is the only chance of cure. If we look at the 5-year overall survival, it is very low, only 4.6%. However, for tumors smaller than 2 centimeters, the 5-year survival rate is 80%. So it is key that these tumors are identified as early as possible and characterized as well as possible. And the techniques to do that are usually MRI, endoscopic ultrasound, and CT. So our aim is to find the best performing of them in the detection and staging of pancreatic cancer. So the question is, which imaging technique has the best diagnostic performance for pancreatic cancer detection and staging? We stratified our population in patients at risk for PC and patients suspected for PC. The index test would be any kind of radiology examinations, with the pathological examination being the reference test when available. And the outcomes are performance of detection and staging of pancreatic cancer, with the hypothesis being that one investigation provides better results compared to the others. The major clinical implication will be an increase in the survival rates, while for policymaker, it will be important to decrease the number of unnecessary investigations. There is already a published meta-analysis on the topic. However, they cite some limitations, such as the fact that they didn't investigate the staging, they didn't look for the vascular involvement, and also they didn't quantify the time frame between all the imaging tests, which are limitations that we plan to overcome with our study. This is our preliminary search key, which includes one domain for pancreatic cancer, one for imaging tests, one for the idea of diagnosis and staging, and one for randomized control trials and comparative trial studies. At this point, we decided that the topic is feasible, the Prospero is written, and we would submit it very soon. To conclude, I have 2 ongoing projects. The first one I hope to submit by the end of this month, and the second one by the beginning of next year. Thank you for your attention, and I will leave you with the words of George Bernard Shaw: don't wait for opportunity, create it. Thank you.
Thank you very much. Very nice presentation and nice data. The resectability, how much does it depend on the observers, the radiologists, the surgeon, and so on? Because in practice, I see several times that the radiologist says, oh, I think it's irresectable. Then the surgeon says, oh, it can be done, or probably we'll see, or otherwise, other way around, that the radiologist says that it can be resected, and the surgeon says, no way.
I think it's very dependent, but in these studies, as I saw, they write the experience of these radiologists. Usually there are 2 radiologists, and there is Cohen Kappa between them, and also they write about the experience of the surgeons. So I hope we could at least gather the data about their experience and how well the decisions were made.
Mm-hmm.
If I may, one question. In your first project regarding the pain, on your first forest plot, there was huge heterogeneity between the opioids. Do you have some hypothesis why it's so?
I think the heterogeneity was among all the studies, and it is because there are some differences also between the populations. For the opioids, I don't think there is much heterogeneity because most of them cite that morphine was used. So in, I think, 90% of the cases, it was morphine. But again, I think it depends on the tumor size, on the location of the tumor, and things like that.
Thank you.
So in the first project, you looked at methods that manage pain for advanced pancreatic cancer. Did you not come across studies, or did you not want to include studies on the effect of stereotactic body radiation therapy? Because SBRT is also used for palliation of pancreatic cancer and also for pancreatic cancer pain.
The problem was that we didn't find any randomized control trial, and we decided we would include only that. And because there are some ongoing randomized control trials on that, but we couldn't include them.
Is with respect to pain, morphine or opioid administration, is it a good marker? Because there are different countries where the liberality of morphine administration is different. For example, in Hungary, it's quite restricted, and we don't get morphine right away, or early enough. Not even early enough.
You are asking if the fact that they are already taking morphine means that the pain is higher?
Yes,
okay.
In one way. And the other way that they give morphine later on when the pain is a lot more higher.
Unfortunately, there weren't any data mentioning what was the previous treatment for these patients. They only say they are palliative patients with no chances for surgery, and they are brought in these studies. So we couldn't gather data if the first pain treatment was morphine and then something else, or we don't have an analysis with something like that.
Okay.